सर स्टार्ट
ना ना ये भी आना चाहिए पूरा शुरुआत में फर्स्ट फ्रेम में पूरा डिपार्टमेंट.
Okay, good morning, everyone. So, on the behalf of Alkem and the Dental College and Hospital Mumbai, it's my privilege to welcome all of you to this live surgery workshop on periarticular microsurgeries for the management of trauma-induced root resorption. So, this workshop is a unique platform to witness advanced surgical techniques in real time aimed at enhancing our understanding and clinical management in the complex cases involving the root resorption due to the trauma. The program schedule will be the first session will be taken up by Dr. Abrar Sayed and Dr. P.D. Joshi. Then in the afternoon, we will have online deliberation on the cases regarding the management alternative by Dr. Manoj, and then the expert final statement on the deliberated clinical course of action by Dr. Vasundhara Patil. So I also like to welcome our today's guest for the live workshop, Dr. Ajay Chandawale, the Director of Department of Medical Education and Research, Maharashtra, Dr. Vivek Pakmode, Joint Director of Dental Medical Education and the Research, Maharashtra, Dr. Vasundhara Bhat Patil, a Dean, Government Dental College and Hospital, Mumbai, Dr. Abrar Sayed, Professor and HOD, Department of Conservative Dentistry and Endodontics, GDC, Mumbai, Dr. P.D. Joshi, Consultant Endodontics. So we have honored to have our two distinguished experts who will guide us through the live session. Dr. Syed Abrar, the Professor and Head of Department of Conservative Dentistry and Endodontics at GDC Mumbai. So Dr. Abrar Sayed is a Professor and Head of Department of Conservative Dentistry and Endodontics at Government Dental College, Mumbai. With over 2 decades of experience in the clinical teaching, he has been performing the live micro endodontics and other clinical procedures since 2004, establishing himself as a pioneer in the field. So since 2013, he's also worked with a laser, both hard and soft tissue surgeries, and in-clinic CAD/CAM technology in large varieties of the cases. So Dr. Abrar has conducted over 90 in-hand training programs, lectures, and workshops at various national as well as international platforms. He also leads at the Teaching Department of Excellence, the Department of Microdentistry, and Maharashtra University of Health Science, Nashik. So I welcome Dr. Syed Abrar. I also like to welcome Dr. P.D. Joshi, Consultant Endodontist at Lilavati Hospital, Mumbai. And he is the head of the Department of Endodontics at Lilavati Hospital and Medical Research Center, Mumbai. He's an eminent consultant endologist. He's practicing in Mumbai since 1980. His clinic is equipped with the modern equipments in the field of microendodontics, including the surgical operating microscope. And he runs his private practice, mainly focusing on both microendodontics and implants and restorative dentistry. He is on the panel of Bhabha Atomic Center as a consultant endodontics. He conducts a various training program for endodontics for practicing dental surgeons under the various dental association all over the country, abroad, as well as in his own clinic at Mumbai. So I welcome both Dr. P.D. Joshi and Dr. Abrar. Now I hand over session to Dr. Abrar. Over to you, sir.
I thank all of you, the dear participants, for giving enormous response in the form of registrations. We appreciate your desire to upgrade your skill and knowledge with us and make this learning platform a success. Thank you so much. To begin with, the second case that we are going to. So this is the case of the day that we are operating first. A 23 years old male patient visited our department with the fractured front teeth and pain in swelling in the upper jaw region in the gum area. Patient had suffered an automobile accident in 2024, September. Patient did not seek any immediate dental care. After 2 to 3 weeks of trauma, patient developed pain and swelling in the upper front region of the jaw and reported to a local dentist who advised multiple root canal treatments and restorations. Patient did not continue any dental treatment and took a course of medication. Patient gave us a history of bike accident. This was the intraoral picture with multiple fractured anterior teeth. And we can see swellings also. Extraoral picture did not indicate anything significant. Usually, when such patients report to us with anterior trauma, or for that matter, any kind of trauma to the teeth or the jaws, we make it a point to see any extraoral markings because it can be a medical legal case and history may be misrepresented by the patient initially, and later on when the matter comes up for hearing in the courts, we are invited to give our opinions. So we have to appropriately take the data of extraoral injuries if at all seen and intraoral injuries whatever are seen and correlate with the history provided by the patient. Intraoral photographs indicate at least class 3 fractures in all anterior teeth, pulp exposed, and you can see a sinus tract forming here and a paralysis or all, it's a chronic sinus tract related to 1-1 and 1-2 both. Sorry, 1-1 and 2-1. So Ellis class 3 fracture with 1-1 and 2-1. Grade 1 mobility was seen with 2-1 and sinus opening with a patent sinus opening with discharge was seen with 1-1 and a gingival swelling was noted with 2-1. Tenderness of percussion was positive on both the teeth. It was mild to moderate tenderness on percussion. Vitality testing did not yield any response anyways because it's a new trauma. Vitality testing usually should not be performed in these teeth in initial 2 to 3 months. At times, vitality becomes positive even after 1 or 2 years also. But usually it comes back in 2 to 6 months after the trauma. Occlusal view of the upper arch shows fractured anterior teeth and a small palatal vertical fracture, a splinter separated, however attached with the gingival tissue. Lower teeth appear to be not having any trauma and patent fissure caries were observed, which were subsequently advised for management. Radiographic examination revealed 1-1 indicated oblique fracture with diastasis of the fragments. You can see ample space in between and slight tilt onto the mesial side of the fractured fragment with the rest of the root appearing intact and the crown broken. However, 2-1 indicated relatively a fracture which is horizontal in nature. Further investigations, occlusal radiograph confirmed the findings of oblique nature of this fracture probably and more horizontal nature of this, and there is ample amount of gaps in between two. As we all know that there are 4 types of healing that are possible or 4 types of tissue reactions which are possible during the process of fracture and subsequent events in the fractured line. Either these 2 fracture fragments are locked together, they do not move, and there is deposition of calcific material in between. That's a very desirable outcome. Second possible outcome is that you have good periodontal tissue developing in that area, metaplasia of the local undifferentiated mesenchymal cells to deposit new calcific barrier, and you see both the fragment to be healthy without any rarefaction. At times, soft tissue grows in and stays it forever, a healthy connective tissue. Sometimes you develop granulation tissue, subsequent necrosis of the pulpal tissue in either of the fragments, and dissemination of infection. So in this case, both the teeth appear to have dissemination of infection from the necrotic pulps to the tissues inside the fractured areas, and you can see quite a good amount of separation of the fragments. Sagittal view confirms the finding that the fractures are not straight. Root fractures are very complex in nature. You cannot simply describe them as vertical, horizontal, oblique, because they can be multiple fracture, multiple fragmentation, incomplete fracture, complete fracture, crown and root fracture, along with displacement, subluxation, injuries. Lot of mix and matches are possible. So not necessarily that every time you will be able to classify a disease, not a disease, sorry, it's a trauma. So that traumatic injury as specifically horizontal or specifically oblique. You have to take it as it comes, and we have seen the journey of whole investigation. Every single point of time, after every single slide, we are coming to know more and more about circumferential movement of the crack lines here. So we can see in the sagittal view that the fragment appear to be more in height. The linear length of the root, remaining root, is more on the facial side. To be precise, if you see, the tooth appears to be from the cervical line to the apex, 12.9 mm, almost 13 millimeter, and the fracture on the buccal aspect has happened at 8 mm. So 4 mm is the 3 to 4 mm is the height of this tooth on the facial aspect. However, similarly, if you see the tooth number 11 here, you see 2 mm gaping in between them and 2.72 mm. So this indicates that if when you open it surgically, if you want to operate, you will see that there is a very thin and fragile root here. And if you want to access the parallel surface, you'll have to go remove this root piece and insert a micro mirror to get a vision and operative access. So depending on the remaining crown root ratio, we will take a call how much root can be sacrificed to gain access. So we cannot sacrifice any amount of root length just to gain access. That is why we are applying microsurgical techniques to get first of all, the light inside. Subsequently, the mirror throws the light inside and the microscope enlarges that area, and micro instruments and the bioceramic materials give us an opportunity for intervention in those microsurgical sites for retention of the crown and root as far as possible. Similarly, with teeth 2-1, there is a lot of compromise of the crown root ratio here because the fracture is placed moreover in apical area. If you see, it's at the junction of the apical and the middle 1/3, and in the palatal area, if you see, it is exactly in the middle 1/3, moreover toward the cervical area. So, however, the clinical mobility is almost grade 1. This mobility may be declared as inflammatory mobility because the patient is very young, remaining amount of bone is very, very intact. There is no angular bone loss which can be expected if the fracture would have been vertical, because it's almost 5 months post-trauma now, and that much of time is enough for a linear fracture, a vertical fracture, to cause seeping in of salivary ingress and cause vertical or angular bone loss in this. Similar findings, if you see, 8 mm is the length of the palatal fragment here. The palatal root wall is 8 mm in the 2-1, and facially it's almost half. This one. So we will see inside. One interesting finding in this case is in all the projections that we have seen, in all investigations, there is no apical hazening, haziness of the lamina dura or widening of the pedial space, or we don't even see any apical rarefaction or any radiolucency. So it can be assumed that in 2-1, the apical fragment has retained its vitality. However, we have a clear-cut gingival swelling and a gap of 3 to 4 millimeters in between the fractured fragments, the apical fragment and the cervical fragment. We might take a call after we open the tissue up surgically. Okay, we are leaving it to that because in such cases, surgical interventions are indicated very few number of cases, very few number of cases, and cases where it is proven beyond any doubt that the apical fragment is retaining the apical blood supply and its vitality, we may not intervene. But however, we ourselves are intervening surgically. We are irrigating it, we are drilling the bone around that area, we might introduce contaminations to cause subsequent necrosis of the remaining fragment. So it will be an exploratory procedure to decide the fate of this fragment in that tooth. Axial view confirms the two fragments in the other 3 dimension. In axial view, you can see the fracture is clear. Coronal view indicates a good picture about how much the gaps are anticipated once we open, because here it appears good. The moment you open the tissues up, there will be infected granulation tissue in this area, and all that we see is the blood. So after we cure it for ample amount of time and we achieve hemostasis, then only we will be able to inspect the individual fragments here. One good news is that there is no displacement into the nose and the floor of the nose appear to be intact. So final outcome of the CBCT study of the case. oblique root fracture extending from middle to the apical third in 1-1, and horizontal root fracture extending from middle to apical third in 2-1, buccal cortical plate not intact with 2-1. So we can assume that there is more amount of infection which has caused perforation of the buccal cortex in 2-1. However, in the 1-1, we will have to explore the root in the better manner, the way we investigate. The blood work has come out to be of no consequence to us as such. Patient appears to be fit. So now the surgical plan is to, the restorative plan, we have already designed the restorative plan for this patient. After confirming that we are able to control all infectious foci in the tissues first, in the heart tissue, we are able to salvage the roots and the anchorage, then only we will plan for, if at all suppose, because as I initially said, the root fractures are not a single entity which can be determined. They are not always vertical, they are not always horizontal, they are not always oblique. They can be partial, they can be multiple. So we don't know what is going to happen because we see a clear dehiscence in relation to this tooth. This tooth. So once we open up, we might find that there are multiple fractures which went unnoticed on the radiographs as well as on the CBCT. So our plan might change after we open the tissue up. So what we have to keep it in mind that we don't finalize the restorative plan unless and until we are sure of the retention of these teeth due to their endodontic considerations and consideration of periodontal origin, the bone support. This is the final plan of restoration. I think this explains the whole case, and Dr. Kishore sir, your comments please. Yeah. You invite Pakmudi sir.
Vande Mataram, Suprabhat, Namaskar. Good morning to everyone. It gives me immense pleasure to speak on this platform as the Joint Director Dental from Directorate of Medical Education and Research, Mumbai, State of Maharashtra. It is a matter of great joy and pride as one of our institutions, Government Dental College and Hospital, Mumbai, is regularly performing these advanced and minimally invasive surgeries for the patient who seek care in their hospital. An endodontist performing a live microsurgery to such a vast number and variety of audience is the unicity of this event. It was a pleasure to be part of the last program which has benefited an audience of more than 5,000 people so far. I wish best of luck to all the organizers, faculties and above all the participants. I appeal to everyone to participate in the exchange of scientific input and share your personal expertise for the larger interest of learner. Lastly, it is my earnest request and desired dream that we must incorporate stem cell research and robotics in the field of dentistry in general and endodontia in particular. Thanks a lot. Jai Hind, Jai Maharashtra.
क्वेश्चन दिसत नाही मला.
नाही तो करतोय
तो व्हॉट्सअप
तो करतोय WhatsApp
यूट्यूबला बघ ना, कमेंट्सला आहे.
all the participants, they can put the question into the chat box for YouTube. If possible, we're going to answer right now at the time of surgery, or not, we'll be answering in the question answer session later on. So requesting all the participants, if they have any doubts, questions, queries, suggestions, they can put into the chat box of the YouTube. Thank you. चालू करोगे ना, मैं पोस्ट करके रख देता हूँ. ठीक.
Hello, am I audible here? Yeah, the first question which is posted to us right now is, how will you manage 8 mm of vertical fracture, right? Am I right getting that question? The question is, how will I manage 8 millimeters of vertical root fracture? Yeah. So this case, the fracture is oblique. If vertical root fracture, complete or incomplete, has separated your fragments together, and any occlusal loading is causing horizontal separation of the fragment, the prognosis is hopeless. You don't attempt any treatment in those cases at all. So this technically, not being a vertical root fracture, this is an oblique fracture, running from facial to the palatal, moreover, and circumferentially having different dimensions, which I have described in the presentation. Now, the question is about why are we salvaging it, right? So why we are salvaging it? Because patient is very young, willing to save the tooth, and remaining anchorage is sufficient enough for tooth to survive sufficient number of years, because the mobility is almost negligible. I'll show you the case now. एक मिनट ना बेटा इसको. We have completed the intraoral and extraoral scrub. We will start with the process of anesthetizing it. We have this incisor and this incisor in question. This has been treated endodontically. This will be subsequently treated endodontically. And we have opened the axis cavities in both the central incisors and disinfected them right now. And they have not been obturated. Now I will be focusing on a small fractured fragment on the palatal aspect. If you all can see it. Okay, this is the fractured fragment on the palatal aspect as I described. This we'll have to address separately. Okay. And that we can manage because we have unlimited width of the attached gingiva on the palatal aspect. And we will take a call on the long-term retention of the tooth as we find them after we do the surgery. So in cases, if at all we need to extract the tooth, will be an exploratory surgery to finalize suitability of the tooth for long-term restoration. Remove the retractors. Give me cotton. Anesthetic gel, topical or spray. Spray it on this. Relax, Dada. खूपच हळू करणार, एकदम आरामात आरामात करणार, अजिबात काळजी करायची नाही. थ्री cc दिया है ना, राइट साइड पैलेटल. हाँ करा दादा, थोडंसं तोंड बंद करा, थोडंसं बघू. हां ठीक आहे. Relax. Bilateral. Bilateral infraorbital. Bilateral infraorbital blocks being given. करा दादा. तसंच इथं पण वाटेल, थोडंसं उघडायचं आपण तोंड. हां असं. हां एकदम रिलॅक्स राहा. कॉटन प्लीज. हां डिसइन्फेक्टिंग सोल्युशन. दादा बरं आहे तुम्हाला, आरामात बसा, एकदम बारकाईने करणार आहे. प्लेन कॉटन. तोंड करा असं. हां बस, बंद करा थोडंसं. हां आता थोडंसं उघडा तोंड, उघडा थोडंसं अजून. हां बस, आकारा मोठा, आता मोठा करायचा. हां बस असाच मोठा करायचा. Yes. आकरा मोठा. We have completed giving bilateral infraorbital blocks. Now we will give him the infiltrations in the local area. Cotton. These infiltrations ensure that we have good amount of hemostasis locally when we work on the granulation tissue and the flap, and it also gives us good tissue separation. We will obtain entry next to the frenum. Close the mouth. तोंड बंद करा दादा. हाँ, very good. बस. Obtaining entry inside here, and we are depositing the solution on withdrawal of the needle. So we don't have to do multiple pricks. This is deposit during the withdrawal through a single prick on the left side. Going similar on the right side again. Microscope hides nothing. You can see arterial pulse of the vessels supplying the lip and the anterior maxilla. हा समोरचा चेहऱ्याचा वरचा भाग आहे ना मधला, पूर्ण बधीर झाल्यासारखा सुजल्यासारखं वाटेल तुम्हाला. हां, एकदम आरामात बसायचं, तुम्हाला काहीच त्रास होणार नाही आहे. ठीक आहे. न्यू नीडल इन सर्च फॉर अनेस्थीसिया. We are now planning to do palatal anesthesia. शंकित है क्या? शंकित साहब को ज़रा बुलाइए. शंकित बाहर है, माइक्रोस्कोप वाले. हाँ करेंगे. This is the papilla. Come get the canal. हाँ बेटा. We did not get cotton, please. Mouth breathing is more, so meter is frogging, so the video is not clear. थोड़ा नाकानी श्वास घ्या. Akara Muta. Yeah, I've gone into the canal and depositing just a few drops. 2 to 3 drops are more than sufficient. The video is blacked out. Now the patient will be comfortable as we achieve nasopalatal. There is no need of infiltration on the palatal aspect. Once we have gone into the nasopalatal, we have given. So we now proceed with the elevation of the flap. As we are going to work on both the central incisors here, we are going to what we do, we mark the तोंड थोडंसं बंद करा दादा. हा करा. Planning of the incision is we are working on central incisor, this tooth and this tooth. Both the centrals we are working on. So we will go distal to the canine here, okay, and distal to the canine here. Why? First start clavicular incision, going distal to the canine on the left side. शंकित मिले क्या? मिस्टर शंकित गए क्या वो? Tip of the blade resting on the bone. Then single clean controlled circular cut to be made. Separate the papilla, rest your tip of the blade onto the septum, then come. Never repeat your movements. Clean separation. All endo people, all learners, PGs should at least once go and see perio surgeries. The amount of beauty they work with, amazing precision. So much of respect to the tissues. We do these surgeries because we know the roots better than anyone else. We don't claim to be better surgeon than them, definitely not. But roots are known to us. We went up to the central incisor, distal area. See how am I preserving the papilla. The microscope is showing you all the details of what I am doing. Only one small discrepancy here is the central papilla. We have lacerated with a small micro wrong incision. The rest is been preserved beautifully, clinically much more acceptable. ठीक है ना? Is all okay here? Reach to the canine. पेन होता है का? जड आहे ना दादा? हां ठीक आहे. आतमध्ये होत आहे ना? हां बरोबर. पॅलेटली वाटते त्यांना. While taking sutures, he will have to be given palatal infiltration that side, otherwise he will have pain. We have gone distal to the canine. Basic principles of design. Either we include or exclude the whole papilla. Hemostasis, mandatory. So we have come up to here and I'm checking whether we have separated everything well or not. Walking the blunt end of the blade, see I have not separated it here well. So I'll give a small walk to the instrument. See, there is no separation. So in such areas you are likely to suffer a tear of the flap. So be careful. Ensure that you raise the flap well. The way Axis decides success in endodontic procedures, here the flap raising has to be very meticulous. Fine. Then we proceed towards the releasing incisions, which need to be taken from the papilla towards Elide. He is experiencing a little bit of pain in that area. So, don't banda kara dada. So we better give him some infiltration in that area. Questions का है लेट का विचार. Releasing incision has to be taken from the attached tissue towards the free tissue. Beta suction do idhar. Mucogingival junction, yes. I've reached the mucogingival junction. From there I'm now taking the incision for the vertical releasing. So just ensuring that it is clean. We now start elevating the flap. We'll give it in the end. Is that okay? Okay. Better to take, we'll take it. Chalo. Turn around, thoda sa. The respected Jayaprakash Rathod sir, our observer from Maharashtra State Dental Council is here. I request Dr. Kishore sir to welcome him.
So I welcome here the observer from Maharashtra University of Health Sciences, our own Dr. Jayaprakash Rathod. Sir, please. He is currently working as the head of Department of Dentistry at BJ Medical College, Pune. And we are fortunate enough to have him today with us in the surgery. So I welcome you, sir.
मेरा वाला पेरियोस्टियल एलिवेटर टूट गया वो पेरियोस्टियल एलिवेटर टूट गया ऑल राइट दिस इज द वन यू हैव आई हैव 3 of them in my box. I have 3 periosteal elevators. Yeah, this is blunt. We are separating the tissue, soft tissue. बरं आहे ना? सक्शन इंट्राओरल टाक. Complete root dehiscence here. Even the lateral incisor, that is 1-2, shows that's a bone loss here, which was not seen in the CBCT or this. I'll show it to you in the microscope later. So far, no big revelation than what we have seen on the CBCT and on the radiographs. Yes, ample amount of, see this picture, typical of the dissemination of infection and the infected granulation tissue around this tooth. Bone loss here and a small, दादा भीक वाटते है ना, थुंकायचं आहे तुम्हाला. हां, आम्ही काय होत आहे, तुम्ही थुंकू नका, आम्ही सक्शन घेतो. हां, तुम्हाला वाटलं मला थांबवायचं आहे तर तुम्ही फक्त आम्हाला कम्युनिकेट करा, लेफ्ट हँड थोडंसं रेंज करा, आम्ही लगेच काम थांबवूयात. हां, असं काय घाई नाही आपल्याला काम करायची, निवांत करायचं आहे आपल्याला. Okay. As anticipated, the 1-1 is having a load of bone loss. Buccal cortical plate is perforated with granulation tissue attached. This is the crack line of the lateral incisor. Give me a probe. I will get it at a higher magnification slightly. Yes. See this one. This, if you can see carefully. Yes. Suction here. Keep the suction in this place. Cervical line of the tooth. The root starts here. This much of bone loss has happened already. This bone is also not very intact. Okay, but periosteum is holding it together. So this is a precious amount of periosteum to us. So this area is having a partial reflexment of the flap also because of the adherences which is formed because of the inflammatory process. Okay, and now you see that there is a gap here, and this is the granulation tissue we are talking about, and this is the apical fragment of the root which is mobile. You see that? And this is a small window of the bone. This is disseminating infection. This is the infected granulation tissue. This is the root from here the root starts, here the root fragment ends. This is the coronal fragment of the root. And this is the apical 1/3 fragment which is broken. Suction beta, hemostasis, yeah, so that they can see, yes, okay. So I have just inspected it, but as I had told you that there is this lesion, this is only 3 to 4 millimeter, and the palatal part of it is very long. So we have to get it out of a small hole, that we will decide later. First of all, we will dissect this granulation tissue that we are seeing with the right central incisor. And see, ironically, we have seen more clinical mobility in the left incisor and severe bone loss in the right central incisor. Scoop or spoon excavator, right side spoon excavator. Yes, thank you. I'm using a spoon excavator to go inside and excavate this granulation tissue here. Is our audio visual in place? See, this is the infected granulation tissue. Suction it out, please. I am removing it with a small spoon excavator. I have a set of curettes and things, but I think this works the best in these all situations. To avoid canal contamination, we had not removed the dressing from the palatal side of the tooth, that is the axis. So yesterday only we have opened the axis and medicated it, irrigated it well. And this morning also we have irrigated it, the canal. Complete the curettage. You see, this is the fractured fragment which is displaced. I showed you in my presentation that this is displaced. This is quite deeper in its origin, and this is intermaxillary suture. So this has got displaced more mesially. So it has gone towards superior and mesial aspect of the maxilla. So we have to be very careful in doing so. We don't want to sacrifice this intermaxillary suture area. So minimum bone destruction we want to cause there and get that root piece out. And try to treat this remaining root surface. But primary objective is to get rid of all the infected granulation tissue so that you get light inside. Once you get light inside, you get visibility, and you don't get light inside unless you are get rid of the infected granulation tissue as well as the oozing. Suction please here, yeah. Just keep the suction for a while so that you get good amount of. Chalo. This is nice. Now we have reasonable control over here. We are blessed to have a good surgical team together. Nilofer madam, Dr. Nilofer from Department of Periodontology, and Dr. Samir Khaire from Department of Oral Maxillofacial Surgery, Dr. Abhilasha, Head of the Department Maxillofacial Surgery, with us today here. So now we have got our curettage in place. Patient will experience some amount of pain when we try and extract the tooth fragment, which is apical. Now I will remove the dressing. डोळ्यावर ते लाईट पडायला नको म्हणून ठेवलंय हा ते मिरर माउथ मिरर एरोटा चालू आहे ना See, as far as the whole procedure so far is concerned, a probe, straight probe. Good news is that there are no comminuted fracture or there are no multiple fracture lines. Okay, the root is not shattered into pieces. So far, whatever root surface we have inspected under the microscope, it appears to be intact, except the part that we already know of. So let us explore more about these roots and these teeth, whether they are retainable, salvageable, or they are not. Dr. Samir sir is around. And Dr. Nilofer. This is the access cavity preparation. Irrigation, please. Intracanal irrigation we want to do. We have removed the temporary restorative material to what is this? Betadine it has to be. Initially, we are using saline irrigation. As I told you, intracanal medication and irrigation has been done this morning already. So, as I described, we are blessed to have oral and maxillofacial surgeon, very eminent personality from GDC Mumbai, Dr. Samir Khaire with us, and Dr. Abhilasha also, and Dr. Nilofer Attar from Department of Periodontology. And if you see, I am focusing the apical 1/3 in the microscope, and I can see that granulation tissue. If my video is showing sufficient resolution, you see that I am poking and causing bleeding in the apical part of the fracture, okay, from the canal. So we have sufficient access and visibility in both cases. I can see the fragment, apical tissue, which is having, I will enlarge it more. I'm seeing it, but the video, I don't think so it will have resolution. Let me see the video. If yes, yes, I am able to focus, I guess. Yeah, sufficient light. I'll increase some illumination so that I can. So I'm seeing apical tissues here. So going back to the canal and now irrigate it more. Give me betadine for irrigation, please. Yes, thank you. Betadine irrigation should be fine in this case because we are anyways going to crown all these teeth if they survive, and mostly they should. Looking at them right now, whatever we have come so far in this journey, it appears that we should be able to salvage them. We don't know the picture after we have done the procedure completely. Easing out the flap a little bit in the apical direction for having better light penetration in that area and having better access during removal of the fragments. So what we have done, we have gained access to the flap, then we opened up the access preparation of the tooth, irrigated the canals, and now next stage is to irrigate. You can see the needle inside. Suction in the lesion, apex. Yes, you can see my needle coming out. This is the needle. I am irrigating it, and the other tooth. Using spoon excavator, because for microsurgeries this works amazing. Our routine spoon excavator. See these two fracture fragment. I am removing this infected granulation tissue. It's a gap of less than 2 mm here. It is more on the palatal aspect. We have expertise of 2 people in hand here. We are experting that expertise. A periodontist, eminent periodontist from GDC, and a very senior and eminent oral surgeon. Samir sir, your opinion please. How to go ahead? Sir, can you hand him the mic, please?
Dr. Samir Khaire.
Sir, it is mobile, sir. Seat. on the screen, but patient feels the pain. So can I do the extraction right now, sir, or I need to release this bone a little bit here?
No, there is no need to drill bone. It's sufficiently loose.
तुम्हाला थोडंसं दादा ते ना असं जोरात काहीतरी ओढ लागेल तुम्हाला. हां, मी काहीतरी आतमध्ये करतोय आणि हलतंय दात असं वाटेल काहीतरी. हां, दुखणार नाही तुम्हाला. दुखलं तर फक्त लेफ्ट हँड थोडंसं रेस करा, आम्ही तिकडेच थांबून जाऊ. हां, I think this spoon excavator is a decent instrument to do that.
You just have to gently tease it out.
Okay, just see if I am performing it correct, sir. Like this. दादा दुखतंय का तुम्हाला? दात दुखतो? हां, ते कळणार तुम्हाला. हां, कळणार तुम्हाला. दुखणार म्हणजे बघा जरा तुम्हाला ॲक्च्युअल दुखत असेल तर मग आम्ही काहीतरी करू. हां, थोडंसं हलताना ते ओढ लागेल तुम्हाला भरपूर. हां, 2च मिनिट थांबा, होऊन जाईल ते. जास्त काही वेळ नाही खाणार. हां, तुम्ही दीर्घ श्वास घ्या, असा हळू श्वास घ्या. हां, we'll give him a break. Due to retraction, nostrils usually get compromised. And secondly, patient has been given bilateral infraorbital and sufficient infiltration in the labial sulcus. So this anesthetizes the nose also, and patient does not feel friction of the air during ventilation. So due to anxiety, the sensation of breathlessness heightens up. So we have to give ample breaks to the patient so that is comfortable. बरं आहे दादा तुम्हाला? हां, आरामात श्वास घ्या, आरामात बसा. घाई काहीच करायची नाही आपल्याला. इतना बड़ा इंस्ट्रूमेंट. ओके. Samir sir has guided us to use this instrument. Sir only will describe this instrument. I सांगून नाही.
Yeah, the instrument that is being used is a root tip pick elevator. So this gently teases out the root piece from the socket.
Oh.
Yeah, you can see the root piece has sufficiently loosened out. And it can be gently picked out with a tweezer.
Show the vital fragment. See, this is, as we had discussed in the presentation, you still see pinkish tissue here which is healthy. So in most probability this was a vital fragment, and we have a healthy bone here. You can see a very, very healthy bony attachment, and the PDL you can see actually manifestation of the PDL which is ruptured. Chalo, fibrous tissue there. Microscope shows an amazing thing, but I don't think so. Video can show it. Catch hold of the root properly. Yes. हां, दादा झालं ते. हां, आता दुखणार नाही बघा. हां, झालं ते. दुखायचं काम संपलं. थुंकी गिळून टाकायची काय हरकत नाही. आम्ही ते खेचून घ्यायची मशीन वापरतोय ना, त्याच्यानी सगळं, आणि घाण काहीच नाही तोंडात. अजिबात काळजी करायची नाही. हां, गिळून टाका, काहीच होणार नाही. थुंकी गिळायची, काहीच प्रॉब्लेम नाही त्याच्यात. हां, we'll do curettage of the rest of the area. Nilofer madam, now so that whitish tissue that is seen, is that another fragment of the root?
Is this another fragment?
Yes, so there are multiple fractures. So there is another fragment inside. So that has to be removed carefully.
There's a bony dehiscence associated with 1-1. This has to be regenerated by either a bone graft, membrane. We should go for a GBR, but this is an infected site. We will remove the fracture fragment and then we'll judge whether GBR has to be done.
Now, after madam has described the tissue management, I want to first confirm the mobility. So if I see the mobility, the tooth is gently mobile, not much of it, similar to the clinical situation before raising the flap. So this much of bone should be sufficient for tooth retention. The rest I'll leave it to the expertise of the periodontist with us. Madam will talk about it. I want to again irrigate this area and then do the apical part of it. Well, this is basic principle is never allow the tissues to dry. No desiccation should be permitted. That will severely compromise the outcome of the procedure, increase the inflammation post-surgical, hamper the healing process, increase symptoms. So always keep the tissues hydrated. दरवाजा बंद केला पाहिजे, आवाज येतोय. हां. Now we take the burr for where is the control? Foot control, hand control beta. Coolant, get the coolant please. Yeah, papyraceous bone is there. I'm going to snub it out. Beta foot control है, hand control है. Yellow na? No, it's not working. No, this is the micromotor attachment. Don't move, don't. This is the micromotor control. इसको लूज कर. Vertical, I want to adjust the microscope a little bit. Yeah. Good enough. Chalo. Bas. Tighten it up back again. Yes. Thank you. Can I get the coolant, ma'am? Dr. Sandhya, oral maxillofacial surgeon, and Dr. Aditi, postgraduate student. It's all their hard work to put up this whole show together. Management of the patient, management of the whole event. Thank them. दादा घर्षण जाणवेल आपल्याला. हां, दुखणार नाही, आवाजाला नाही घाबरायचं आपण. आरामात बसा दादा. हां, कूलंट प्लीज. थँक यू मॅम. नाईस, गुड. Very gentle movement, and there is a sharp edge here. No sharp edges can be left in any of the tissues, post or pre-surgical, whatever they are, remove them. Always a basic principle. Sharp edges of the bone can have problems, necrosis. This is papyraceous bone about to be destroyed. Remove it. All thin areas to be removed. I don't want to do the root resection as such, but I am gaining access by minimal removal, just touching it. Getting back to the spoon excavator. See, this whole tissue has to be out, that whole granulation tissue. Otherwise, we can't repair this, because this is undesirable tissue. This is not healthy tissue. This takes a little bit of time. As soon as we go to the center, patient will experience some pain on the mesial wall naturally because of the presence of neurovascular bundle. We have gone inside the canal and deposited solution of local anesthetic, but still patient is bound to get some pain. Continuous कौन बोलता है इथे? शांतरा. Can you not talk please? The thing which was appearing like roof fragment there, it was actually the PDL. First time I also saw a PDL, full PDL, which I could remove. The video has captured those moments. I'm going to love it when I see it again. I've never seen PDL like that. A taut membrane, clinically seen under the microscope. Amazing. This is to your approval. Samir sir, are we okay here? Yes. Are we going well, sir? Okay. We have reasonably curetaged it. Slight gentle pain to the patient is most common in this area. Whenever all your life you work, you can't control this pain. Always under the local, whenever you work, you curate towards the palate and the medial wall, patient will experience some discomfort. In spite of best of the anesthesia you achieve, so don't mind if the patient is getting it, but ensure that all pathological material, once you gain a surgical access, once you go in, remove it all. Yes, now the tissue is clean, very, very clean. दादा झालं बघा व्यवस्थित झालं आपलं काम चाललंय आता एका दाताचा शेवटचा टप्पा राहिलाय तो तुकडा जो पडला होता ना तो तुकडा काढून टाकला आपण इधर ध्यान दो बेटा हां लांब श्वास घ्या दीर्घ श्वास घ्या हळू श्वास घ्या नाही होणार काहीच आरामात बसा रिलॅक्स आहे बरं आहे ना दादा हां आता आपण राईट साईडचं बघू टर्न करा इथे हां अच्छा हां हां रिलॅक्स व्हा संपला ते पेनफुल भाग संपला तो दात काढायचा भाग संपला ना काहीच राहणार नाही दुखणार तुम्हाला Give me scissor please. I will poke a small gauze I am packing a gauze there to control hemostasis, so achieve hemostasis. Packing the gauze for hemostasis in this area. Now concentrating on the right side where we have more amount of granulation tissue and this is this growth which is emerging out of this tissue is also inflammatory, but you can't cut it because it's connected to the sinus tract. It is epithelialized from inside. So usually leave it alone for healing. How to handle ingress of the tissue, soft tissue during healing process, that we will subsequently see. Let us first concentrate on the root. Curettage starts here and this root is totally displaced inside. If it is within the purview of my expertise, I will attempt it, or else I'll leave it to the oral surgeon to do. Yeah, slight elevation of the flap in that area would be better, but tissue is too adherent. So, and we have the margin clear. Patient is going to experience some amount of discomfort if I move it. दादा थोडंसं राईट साईड सारखं इथे पण थोडंसं दुखणार. समीर सर आहेत का मॅडम? बोलवा ना. You will take it over, extraction. One fragment will be taken over for extraction by the periodontist. We are taking a break, giving a patient also a break for a few minutes. तू मत ले, अरे इसमें आएगा तू बिना ग्लव्स का. रेडी. बस चल, बस हो गया बेटा, बहुत हो गया. ओके, यू विल एक्सट्रैक्ट. We have come back on the audio line. Okay. So this root piece is a little bit more challenging because it's positioned mesially and apically. It is broken and mesially displaced. As we had confirmed on the CBCT, it is palatally and mesially displaced. So we are here taking care not to insert that root piece, not to force that root piece into the canal or into the floor of the nose. So what madam has just now done is release a little bit of bone in that area and clean the granulation tissue so that there is hemostasis, visibility is increased, and operative access is increased. Yeah, now you can clearly see the root piece, apical fragment. Is here. As we had discussed, the location of this displaced root fragment is almost gone and compacted the cancellous bone and placed itself mesially and palatally near the intermaxillary suture. So if I force this too much, I'm likely to push in the nasopalatine canal, compressing the nerve, causing prolonged paresthesia to the patient. Or if I force it more apically, I'm likely to push it into the nose. So what a periodontist, Dr. Nilofer, has done is given her a clean access, and now Dr. Samir is going to extract the root piece. Sir. अरे बाप रे, असलं काय आमच्याकडे नसतं. What do you want? Sterilim is here. प्लास्टिक ड्रेप है, सर्किल ड्रेप है. ये गाउन है, सर्जिकल गाउन. नहीं वो नहीं. Yes, we will radiograph the tooth after this root piece is out. Is it out? Huh? Okay, take your call. I'll change the angulation a little bit. Wait, beta, thoda sa. So sorry. We avoid touching the burr onto the root piece so that we get a purchase point. Madam is very careful to only touch and the PDL is seen. If we want to demarcate we can use the dye. The PDL will be demarcated. We put methylene blue. After isolation, we will put methylene blue there. It delineates the entire periodontal ligament so that we can peacefully control the hemostasis. We can remove the root piece with a lot of care in that area, not to leave it because it's the potential focus of infection. ऐका ना. हाँ सर, 1 root piece is out.
थोड़ा प्रेशर
आता काही करत नाही, आता काही जाणवत
एले चला ही नहीं गया एले नहीं आते ನಿಲ್ಲಿಸಿರಿಂದೆ surgical sponge. Sponge. Do we have the sponge? Gel foam. Where is it? Take it off. We'll put gel foam and then compact the MTA. Cut it. बसा मैडम
पहिले कनेक्ट केलं नंतर आपलं सर्जिकल सर्जरीचा आपल्याला थिकनेस ऑफ द ब्लेड आणि कन्सिस्टन्सी.
सर व्हॉट्सॲप मी द क्वेश्चन्स या माझ्यावर घ्या. We have been given a few questions here. The question is why obturation was not done before the surgical intervention. As we all know, the fractures are oblique in nature. It's a combination of horizontal, oblique, vertical root fracture. So there is no defined apex. Practically speaking, there was 4.5 millimeter difference between the facial root wall and the parallel root wall. So one would not understand how much length to be kept for the obturating material. Secondly, there is no confining effect to the obturation. There is nothing called as apical matrix or constriction against which a compaction can be achieved. Thirdly, we were not knowing if there are multiple fractures inside which would necessitate root extraction or the tooth extraction. After we have explored it, we've realized that even there is a complete dehiscence on the left side, the mobility still is limited. So we're retaining the tooth. So now what we are doing is obtaining a direct access through the surgery and orthograde access through the coronal area. We will have something in the apical cavity to block the flow of material apically, to avoid over-extrusion of the material and do orthograde obturation from the coronal end. And finally, if need be, we will graft it and put a membrane to avoid ingress of the soft tissue later so that we have a nice hard tissue healing in that area. That was the purpose we have not done an obturation. And barely there is any root present, gutta percha cannot be compacted. So we would prefer all MTA obturation in both the roots in these cases. I hope I answered the question. The root is being extracted. There is a question in which cases apical fragment needs to be removed and in which cases we decide to retain the apical fragment. We usually do not remove apical fragments. In most of the cases, Apical fragments in root fractures remain vital, and they remain vital for lifetime. So any root fracture that you see in the apical 1/3 needs to be followed up. If there is no tenderness, no pus discharge, no sinus tract formation, and no evidence of apical rarefaction, you never remove any apical root fragment. Once you establish that there is apical disease, or the fracture lines indicate that there is a focus of infection there which is disseminating rarefaction in the surrounding tissues, then you take a call. If suppose you have a very vital fragment in the apex with the entire lamina dura intact, and you see bone formation around the coronal end of the apical fragment, if the bone is protecting it for a very long duration of time and there is a dissemination related to the coronal fragment, then we might decide not to remove the apical fragment, but that because that is necessitating a separate surgical procedure itself. So we can think of removing this. But however, if it is coming in the way of an implant, we'll have to go for removal. So such cases we plan. If the case is vital, both the fragments retain vitality for lifetime, and pulp sensibility returns after 2 months, 6 months, or even up to 1 or 2 years without any signs of progressive infection, we retain both the fragments in fractured state in the tooth, and patient only keeps on coming for follow-ups. For example, a patient comes to your clinic and shows that there is a clear fracture with diastasis. The fracture fragments are united or separated by 3 to 4 millimeter also. However, there is no evidence of any loss of lamina dura, no evidence of rarefaction or spread of infection, and both the fragments seem to have a symptomatic condition. Then we don't do any intervention and keep on following the patient up radiographically 6 months, 3 months, 6 months, 1 year, then yearly basis on almost up to 4 to 5 years, or up to even maybe 10 years, because these infections are very insidious in onset. They very slowly grow. The non-vitality of the tooth may appear after 5 or 6 years also. Sometime after 15 years of the fracture, you get periapical lesion. So you have to be careful. And in many cases in the apical fragment, as it is, there is an irritation because of the fracture, either coronal or apical fracture may indicate total calcification or obliteration of the pulp chamber. So that we have to be carefully monitoring about. I hope I answered the question. Samir sir, is the fragment out?
In the radiograph, and we will proceed.
Okay. Any other questions, sir?
Yes, sir.
Since there is labial dehiscence, how is the dehiscence going to be managed? Ma'am, you can answer this question. Since there is a labial dehiscence, Dr. Nilofar Attar with us, she is going to answer this question. The question, ma'am, is, since there is a labial dehiscence, how is the dehiscence going to be managed? Can I have the mic?
Labial dehiscence, usually we go for GBR, guided bone regeneration. So we have to do root biomodification, then bone graft covered by membrane and a coronally displaced flap. So this is how we manage dehiscence.
What will be proceeding with this case?
In this case, first we will judge because there's a lot of infected area, we have done a lot of degranulation. After the debridement, we'll decide whether to go for a bone graft or close or do a open flap debridement.
Okay, thank you, ma'am. Hope this answers the questions.
All is well. Could you see that in the car? You saw it in the car while coming? You didn't log in? Okay. Is it out, sir?
No, no. I just look it here. With respect to root was string, it's not so. I'll uncover it on the medial side only.
Uncovering करना पड़ेगा?
हाँ.
Okay.
Sir, the elevation किया है.
मुझे दे. Did it next syringe? Sir, if I give you this ink, no, this will give you exact PDL, and it's mobile. If I paint this, no, disclosing agent. Wait, isolation. No, wait, sir, wait. Do the mop it up well. Control the hemorrhage. Just apply it in that root piece area. Yes. Bas. And irrigate now. Suction. Give me saline. Wait. Suction, beta. Suction. PDL will show. You see the PDL now? That's the line. This is the PDL, sir. Yes, that's the root piece. We have used the disclosing agent, methylene blue, because the bone and the root piece color were almost similar. थोडंसं दादा वाटेल हलकं से ओढ लागेल तुम्हाला बरं का. रिलॅक्स व्हा लेफ्ट साईडला कसं जाणवलं ना तसं जाणवणार बाकी काही नाही. What do you want? Removing some amount of bone in that vicinity so that we get a line of draw. It is mechanically locked because of the natural curvature of the root in the apex and displacement. So sir is making it accessible for us to elevate it by removal of a little bit of bone. Slight discomfort of the patient is very natural here because whenever that root piece is going to move, it's going to cause some pressure on the canal. The canal carries neurovascular bundle. In spite of profound anesthesia, the patient will feel the pain a little bit. And we all know that the palatal wall of the fragment is too long. So there are triple interlocking of the root piece inside: mesial displacement, palatal displacement, and it being palatally very long and facially being short. Yes, now you can see the frank mobility of the root piece. Root piece has become mobile now. Very gently, sir is doing it, minimizing discomfort to the patient. And it's out almost. Beautiful. दादा बरं आहे ना? हां, आता नाही निघालं ते गेलं. हां, आता काय दुखणार नाही आपल्याला. आता झालं बघा. हां, लेफ्टचं झालं पहिलं आणि आता राईटचं पण झालंय. सी द रूट पीस हिअर. फोकस फोकस फोकस. दिस इज द रूट फ्रॅगमेंट हिअर. एक मिनिट मी फोकस करतो नाही तर. हां, दॅट इज द रूट फ्रॅगमेंट सर हॅज टेकन आउट. चलो थँक्यू सो मच सर. क्युर टच करेगी तू? क्युर टच कर ले. झालं आता दुखायचं काम संपलं तुमचं. हां ना हां, लेट्स डेलिब्रेट द प्लॅन हिअर. Pack the cavity and then put MTA obturation from the orthograde. Okay, remove the gel foam. You put the graft and the membrane. Sir, done? Suits well? हाँ? नहीं क्या चलता है. लाइफ में लगी हुई अपनी तो क्या है अभी क्या है. हाँ? चल बेटा. I'll take over. Okay. Yes. Relax. हां, आरामात थांबा. काही घाई नाही आपल्याला. अजिबात घाई नाही करायची आपल्याला. आरामात काम करायचं आहे. गिव मी बीटाडीन. मॉप द टिश्यूज. रूट पीसेस फोटोग्राफ केले पाहिजे. हां, we have kept it out of the focus. We have given a break to the patient so that we continuously don't work on him. But loosen it up. हाँ, लूज कर. बस रिलॅक्स होता. तुम्ही आरामात बसा. आम्ही हे सगळं करणार. तुम्ही फक्त रिलॅक्स राहू. आम्ही बाकीचं करतो. तुमच्यासाठी हे चाललंय. तुम्ही आमच्यासाठी काही करायचं नाही. तुम्ही रिमाज बघा. पहिलं तुमचं काम व्यवस्थित झालं पाहिजे. बंद करा. तोंड बंद ठेवा. आरामात बसा. तुम्हाला ब्रेक दिला मी. असंच ॲडजस्टमेंट करतो माझ्या माइंडवर. तुम्ही रिलॅक्स व्हा. आरामात. हां, गिव मी अनदर पेअर ऑफ ग्लव्स प्लीज. ग्लव्स दे दुसरे. हाँ, टाइट इट अप. नो प्रॉब्लम. चालू करू दे काम. बेटा जस्ट डोंट रिट्रैक्ट इट टू मच. अरे अरे येड़े लोग. Ah, that is there. I was searching Sankit to do it. Thank you, sir. See, the plan now is to obturate the tooth. Audio जा रहा है मेरा? On है? Okay. So we are going to put a gauze here to achieve hemostasis because there is a small extraction socket which is still oozing here. So we are going to pack a gauze and we are going to focus on the left tooth. We are going to focus on the 2-1. Relax, relax, Dada, relax. Haan. We are going to focus on this where we have worked already and काय दुखतं. हां अच्छा ठीक आहे, कमी होऊन जाईल ना ते. थोडं रिलॅक्स व्हा दादा तुम्ही. Increasing the magnification to show what's happening. We are going from the canal. We need an apical matrix again with something can be gel foam please. Now I will छोटा वाला मिरर देना, apical mirror, microsurgical mirror. हाँ सर का है देखो एक. I am focusing it on the canal here. This is the picture of the root apex. As we can see it, and I'm going to block this with this mirror and do the obturation with the MTA. तोंड उघडं ठेवा दादा. हां पट्टी जेलफोमची गरजच पडणार नाही. मग कनाल ड्राय करायची आपल्याला. गिव मी कॉटन हिअर. दादा रिलॅक्स व्हा. संपलं आता ते तुमचं पेनचा भाग नाही आता काहीच. हां we are going to keep this micro mirror as an apical barrier against which MTA can be packed. Dr. P.D. Joshi sir, the stalwart is with us. So that's okay. How is it going? Plan was to put gel foam here, but we have achieved sufficient hemostasis and this mirror is quite well fitting in that area. So now what we do is we put टिप किधर है इसका? ये साइड से आ रहा है, साइड से आ रहा है, क्या हुआ देखो इसको, टाइटन इट अप प्रॉपर्ली सर, mop it, mop the tissue. There is moisture in the tissue which is not good for the MTA. Hemostasis is mandatory. See the MTA going. We have to mind how much we are depositing. अपेक्स पढ़ना ये तस नहीं है, हाँ नहीं जाएगा ना, हाउ विल गो, गेट अनदर सिरिंज, रिट्रैक्शन दो, रिट्रैक्शन दो, रिट्रैक्शन दो इधर, थोड़ा खाली बगा, हाँ बस, हाँ सर moisture control is good there, my problem is the syringe. Where is the tip of this? Give me a tip. Yes, sir, very small. थोड़े शांत व्हा दादा. Material. I have deposited MTA putty in that area. Showing you how it goes in the canal. Plugger. You see that in the canal, and then retain it apically. Confining effect is given by the cotton which I have kept, earlier given by the micro mirror. See, I have not violated it. So you can see that the apical end MTA placement is controlled. Holding it, then using a plugger in this area for gentle compaction. नहीं, movement नहीं होना चाहिए. हाँ. See the margins and then take it off. The MT has come out. Then pack it well. So where we come out, go back inside again, and then I will show it to you how it has taken a shape in the apex. See the MTA hole fill. All the periphery of the root is seen. I'll clean the mirror a little bit. so that the visibility is good. See the whole MTA and entire circumference of the root is seen. The whole root is filled with the MTA. Similar exercise on the right side. First irrigate with betadine the canal and the apical area lesion. Take the betadine out through suctioning. Don't allow it to contact the adjacent tooth MTA, okay? Yes, there only you have to do proper suctioning. Now do intraoral sectioning. Now we'll aspirate the excess amount of betadine, then dry the canal. I have aspirated it. Now we'll dry the canal using an endodontic instrument and the cotton. Yeah, I'll wrap it around. Thank you, sir. Removed the remnants of betadine from there, and now removing the cotton, the dressing given. Maintaining this as a confining solution at the apical area. This is a little bit of irregular fragment of the fracture, still workable. Do not move. Don't move. थोड़ा सा हालू नका दादा तुम्ही please. हालू नका दादा. 2 ते 5 मिनिटं द्या आता. झालं काम आपलं. Confirming the material placement inside is the mouth breather. Yes, coronally I have to deposit some amount of material more here. Coronal deposition you are seeing here. नहीं हिलाओ मत पेशेंट को बेटा. हाँ काढ़ा काढ़ा. Plugger. He wants a break. Patient wants a break. नाकाने श्वास घ्यायचा प्रयत्न करा 1 मिनिटं. As he is a mouth breather, it fogs. Hold the suction close to the mirror. What I'm doing is slight gentle compaction of the material, not affecting the apical extrusion. Yes. As I have compacted that in the canal, After compaction, I have to go back again. Suction nazdik rakho beta. हाँ. I don't have the luxury of the rubber dam, but isolation maintained well. Thanks to Sandhya madam here and Aditi madam as well. Take a small cotton piece to compact. In the end of the procedure, we are going to extract the palatal splinter of the root. झालं 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 चला आता क्लोजरचा वेळ आलेला आहे. हां, now we will compact it from the other end. See it there? Yes, we are compacting it through the other end, and I'll show you how it looks from there. It looks good from here. If you can see all the margins seen till the palatal. It looks slightly overfilled here, and margins are not compacted. You see that the margin is not compacted. So I need some good instrument to go there and compact that material a little bit more so that I achieve reasonable properties of sealing by the MTA. As I told you that this root has not been resected apically to salvage its length. No. The diameter of the root is too big for the small compaction. So it has to be compacted through a flatter instrument. If you do that, you make it irregular, non-uniform. You need uniform procedure. Now what we will do is, we will wait for the MTA to set. Not allow contamination of the moisture. I am putting a relatively drier gauze, cotton here, or a gauze, whatever you can. We now start the procedure for closure. Nilofer ma'am? Grafting? Okay, give me the grafting material please, ma'am. I'm cleaning the excessive amount of mineral trioxide aggregate from the tissue. Relax व्हा दादा. Okay का? शांत व्हा जरा. We have a clean tissue here. देऊन टाका. We will deposit it like this directly. The bone being grafted. Repaired surface. दादा काय होतंय तुम्हाला? काय होतंय? अच्छा ठीक आहे, कमी होऊन जाईल. आतमध्ये अच्छा तिकडे ओके ठीक आहे आम्ही करतो आता हां आम्ही अनेस्थेशिया देऊन टाकू थोडंसं इज एक्सपिरियन्सिंग अ लिटल बिट ऑफ पेन पैराडल देना पडेगा दादा रिलॅक्स व्हा थोडं रिलॅक्स व्हा करतो ते हां मी काळजी करू नका न्यू एल टू बी फिल्ड अँड ऑन द राईट साईड वी नीड टू ग्राफ्ट द मटेरियल नाव We are covering the root surface with the graft material. आता रिलॅक्स व्हा थोडा वेळ वी आर गिविंग अ ब्रेक टू द पेशंट इज बीन व्हेरी कोऑपरेटिव्ह अनेस्थेशिया देतो आता थोडंसं
इंजेक्शन देतो आता झालं होत आलं सिमेंट भरून झालं सगळं झालं तर फक्त टाके घालायचे बाकी सर्जरी होत आली
सर्जरी ऑलमोस्ट संपली फक्त टाके द्यायचे राहिले आता हां दादा झालं हां giving a break to the patient. What I have done just now is deposited the bone graft. Madam will elaborate on further procedure. Over to Dr. Neelofer Attar. We are augmenting the anesthesia by depositing some solution in the parad aspect.
We have given a Nova bone putty as a bone graft material. We'll be covering it by a membrane with the help of a resorbable suture. Okay, we are letting the bone graft set and then we'll proceed with the membrane placement.
epithelium will start growing towards the root piece socket, and there'll be fibrous healing instead of the bony healing. And also there would be substantial recession of the labial flap. So in this case, to avoid all the complications, you place a slowly reducing graft material like xenograft or allograft. So here in this case, we had the xenograft with us, Nova bone. So we placed it over that, and it's in the form of a putty, so it's easy to adapt on the surface. Over that, you place your collagen membrane to cover the graft, so that when the healing takes place, the epithelium does not grow through the membrane into the graft and allow the graft to be rejected. So the membrane acts like a scaffold and also acts like a protection to the graft. So this is needed to improve the labial bulk of the bone. At the same time, even if we don't get any bone formation on the dehiscence, it will still prevent any unnecessary recession of the tissue. I hope that answers the question. Thank you. Any other question? Ask sir if there is any other question.
The next question is, the next question here is, are we planning to splint these teeth, or we are not planning to splint these teeth? So,
splinting depends upon the mobility and the trauma associated with bite. So in case patient is having deep bite and also there is a minor mobility, then in that case you might need to splint it. But as you saw during the entire procedure, there was no movement visible on the tooth. Even while she is suturing, you don't see teeth looking mobile. So I think they will hold good. Only thing we need to take care of is that they are out of occlusion while it is healing. So there is no direct force on the tooth. So patient would be asked not to bite on it. We will make sure that the teeth are out of occlusion just before we discharge the patient, and that should hold. But otherwise you can splint either using a removable splint, or you can just join the front 4 teeth with a small metal arch wire and splint the teeth together, which can be done even little later. Thank you.
another question here is, why we have not used a cheek retractor or lip retractor for better access. In this case, we are working simultaneously on both the incisors. So whenever we wanted, an assistant is trained enough to retract the required amount of tissue. Hence, we did not feel the need of using it. And secondly, at times it irritated the tissues, and we never realized that it will be required. And microscopic surgeries, the opening is very small. As you have seen, that the window prepared is very, very small. Extraction could be done very easily through a very, very small opening. And we stayed the periodontal ligament, and then we directed it through an appropriate route. So wider retraction, wider preparation is not required. However, the flap raised is very, very good, because if you have a poor flap, you end up doing a lot of problems in the surgery itself. So I hope that answered the question. And somebody has asked why we have not done a retrograde MTA filling. So as it's a very, very large canal, a retrograde MTA filling is done when the apex is narrow, when you prepare a retrograde cavity and you have obturation in place in the canal. In this case, the canal is funnel shaped. There is no apical terminus, there is no apical constriction again which filling can be done orthograde, and then a retrograde cavity can be prepared. As you saw, a micro mirror was used as a limiting agent for mineral trioxide aggregate, against which the MTA was compacted through an orthograde approach. Hence, there was no retrograde filling done. Next question, over to sir, please.
So the next question is about what is the plan for the post-endodontic restoration?
Well, post-endodontic restoration, first of all, we need to wait for some time for healing. The sutures have to be removed after 7 days, and then you can plan doing either a direct composite class 4 build-up on the tooth, or you can place a laminate as per requirement of the patient. So you need to discuss this with the patient at that point in time. But my suggestion in this case would be to do composite direct build-up post removal of the sutures and leave it like that while it is healing. Once you verify complete healing, bone formation, good lamina dura and reduced mobility, then you can decide a further definitive restoration for the patient.
This is the digital design of the smile that we have thought of. Okay, this is a digital smile design of this patient, which will ultimately do. Sir, I hope any corrections you want to suggest, sir?
No, this is very nice, and I think it's following the outline of the smile, especially with the line in line with canines. So once you build it up with composite, either with a putty index or directly as well, you will be able to get a good smile line and semi-permanent build up with composite. After that, you can think of either crowns or laminates at a future date once the healing takes place. So you don't invest into expensive crowns, all ceramic crowns at this point in time while you are waiting for healing.
Thank you, sir. Can we next question to sir? So next question is, what should be the thickness of the apical plug and consistency? There is entire obturation done with the MTA in this case, so there's no question of an apical plug. Secondly, in this case, we have used MTA putty. Because the canal was large, incremental placement would have been cumbersome, and there is a confining effect in the apex of a micro mirror. So putty was selected to deposit the material during withdrawal using a syringe, which could be compacted against the apical instrument using a cotton ball. So I think that reasonably answers the question, and sir, please put some light on it.
Well, this is the correct way of doing it when you're doing it from the coronal end.
Let him answer some questions.
Mostly, if your question is how much should be the retrograde, it is about 3 mm from the surface where you have resected the root in a normal episectomy. So you resect 3 mm of the root, and then you prepare retrograde 3 mm of the canal, and then you place MTA against a matrix of Gadapacha in the canal.
Sir, somebody is asking the prognosis of this case.
Oblique horizontal fracture.
I think the prognosis will be still good, and the tooth can last for a very long time. Till the time there would be gingival recession and pocket formation on the gingival margin. That would reduce the support of the root. But root will, if you follow it up, in 6 months or 1 year's time, root would be fairly covered with bone, and there would be enough grip on the root.
And in terms of statistics, if we want to talk about, only this constitutes, the root fractures constitute around 0.7 to 8% of the injuries of the hard tissues of the teeth. Almost 25% of them on an average tend to develop pulp necrosis, which we have got in this case. And survival rate of these teeth after the treatment is approximately, as per the literature, 88%. So we have quite a fair chance of survival. And as we have initially discussed, that clinically it seemed different. After IOPS it was different. After CBCT it was different. So this surgery, as we declared initially, is not only a curative surgery or a therapeutic procedure, it was an exploratory procedure to find out if there are additional crack which would necessitate extraction ultimately. So if we would have found any new fracture lines which would have been deleterious for the future survival of this tooth, we would have thought of extracting. So we had an entire legion of experts here, Dr. P.D. Joshi sir, Dr. Nilofer Attar, Dr. Samir Khaire, Dr. Abhilasha, all of us were there, and we had prepared an armamentarium even for extraction. So I hope that answers the question.
And according to research, if you do episectomy and you resect 3 millimeter of the root, that 3 millimeter comprises of only 10% of the strength, 5 to 10% of the overall periodontal strength of the tooth. So which means when you are resecting, you are retaining most of the bone support to the tooth. So this is almost like a resection that would you normally do in your episectomy. So this is about 3 to 4 millimeter of the length of the root. So you are actually not removing too much of a tooth substance during this procedure.
And normally, as sir would agree, that in our regular clinical procedures, the do's and don'ts are very clear. The objectives of the treatments are clear, and we go as per the contemplation and the planned procedures. However, in trauma, it is highly subjective. Trauma is bizarre. Tissue response can be multifactorial. If you see young patients, early teens and all, they have highest incidence of trauma. However, the root fractures are least common in that age group, owing to the elasticity of the alveolus. However, the root fractures are more common in the second and third decades of life. And as discussed, the management of root fracture also depend on size, location, extension, remaining bone support, vitality, non-vitality, mobility, how much displacement has happened, how much intrusive or extrusive luxation or lateral luxation has happened, and ultimately we feel quality of the outcome of the endodontic procedure in infected teeth and occlusion. Because in the long term, if you tend to restore the tooth with appropriate direction of forces, without any parafunctional extreme forces, it will survive. If you fail to establish appropriate occlusion, everything that you have done is already on a stake. Thank you. I think we should complete. Ma'am, suturing is complete? How many? 3 more sutures are to go. Okay. We'll take one more question. Yeah. 12:45. I'll take the next question.
So there is one question: how to check clinically the vitality of the apical third segment?
Why do you need to check it in the first place?
It's on? Mic is on? Yeah.
And secondly, as Sir Abrar sir has already before the surgery only mentioned that mostly the apical third fragment is the pulp tissue is going to be vital, because we are not seeing any changes neither on the CBCT, neither on the radiograph at the apex of the root tip. And when he removed the tip at the time after the surgery, he showed you the vital tissue that was present inside the canal. So he already anticipated on the radiograph and CBCT. And there is, as Sir has said, there is hardly going to make any difference. We are going to remove the apical tip, whether the tissue is vital or non-vital. And Sir has already anticipated, and it was found to be true after the removal of the root apex. Thank you.
And in the long term, if the apical fragment has retained its vitality, as I initially said, the coronal stump of the root of the apical fragment, there can be deposition of the bone there, a crypt-like structure or a confining effect of the healthy bone will be seen there. In the tip of that apical fragment root, you will not see haziness of the lamina dura, widening of the pedial space, or development of any granuloma type lesion, or rarefaction. So ultimately you will see that it is spick and span, very healthy. So you may think of not touching it at all. But in such cases where there is a disseminated infection, there is a sinus tract, there is a bone loss, it is mandatory to extract the apical fragment. Once you are going in surgically, might as well use the event to remove all possible foci of infection for future.
I hope this is clear, the doubts, and answered all the questions that were posted. Not all, but what maximum what we can do, we have done it. So just the suturing is about to finish. So the next surgery where we'll be starting exactly at 1:45. So I hope you all to join again at 1:45. Thanks a lot, everybody.
Suture is remaining. After that, Dr. Nilofer Attar will conclude. Thank you.
So we have completed the flap suturing. Only care while suturing, we have to take care that we don't expose the membrane. Post-operatively, it's very important that if a membrane exposure is evident, then there will be a high chances of infection at that area. So whenever we opt for a membrane, first we try to check out whether we can close the surgical site completely. So here we have checked that I can coronally advance the flap and cover the surgical site, and then we went for a membrane, and that care we have taken during the suturing as well. Okay, so here the bone graft, the membrane is completely enclosed in the surgical site. Thank you.
of the surgery. This surgery will be done by Dr. Abrar Sayed sir and Dr. P.D. Doshi sir. Now this case is basically related to internal resorption and external resorption. So I will hand over this mic to Dr. P.D. Doshi sir for the case discussion.
Okay, so the patient is a 28-year-old male and was reported to the department with the chief complaint of decayed carious upper anterior tooth or teeth. So his prime concern was this proximal caries, class 3 caries and class 4 caries, for which he had come. Even he wanted to change his restoration. The history was there of trauma on the tooth 10 years back in a road accident, but he didn't do anything about it because he didn't have any symptoms at that point in time. Clinically, when we examined the patient had no swelling, no discoloration, no evidence of any sinus tract on the surface of the gingival tissue. Only a small amount of periodontal pocket was seen on the right central, that's 1-1, and we thought of exploring it further. There was no mobility or sinus tract or any discharge from there. Radiographically, when we examined this patient, we saw this external resorption. And of course, we had taken the X-ray for the caries to see whether the pulp is exposed or not, whether we should indulge into RC or some other kind of a procedure. But then we found this external resorption. We informed the patient that this has to be treated, otherwise it will progress further into the tooth and you can lose the tooth. So patient agreed for the treatment along with his caries management. We also asked the patient to get CBCT done, and what you can see is the external resorption. It's kind of a round patch from the surface of the root near the cemento-enamel junction, partially into the cementum towards the apical part on the root, partially on the enamel on the cervical part of the root. So it's combining between the two and quite circular and predominantly on the labial aspect. So here you can see the defect is entirely labial. The pulp tissue is very close, and here you can see it's almost exposed. And this part shows the CBCT, shows the height and the width of the lesion. Now this is a progressive lesion. If you see the theoretically, this would be a class 2. Because class 1 would be on the surface, class 2 would be going deeper but not involving the other side of the pulp, and class 3 would also involve around the pulp. So this is class 2 lesion theoretically. And axial view shows the lesion predominantly buccal or labial, but slightly going towards the distolabial margin. Though the pulp shows it to be 0.85 millimeter away, there are two theories about it. You can either during the surgery excavate and see whether the pulp is involved or not, and then complete the root canal procedure over there, or you can do it beforehand, intentional pulpectomy, and then complete your obturation so that you play safe in this case. Now this is only one section, so if you see series of sections, you may find that somewhere the pulp is even closer than this. Because if you see the lengthwise, it would be close to about 4 millimeter. So this is not the section of all the 4 millimeters with us. So that's the theory which is telling you this is a class 2 lesion And this is class 3 and class 4. It is not like that. It is not even class 1. It's exactly class 2. The external, there are other classifications, but I think if we just look into this, the height, supracrestal at the CEJ level, circumferential spread, 90 degrees, lesion in dentine, proximity to canal, and extend into middle 1/3, but not beyond middle 1/3. It's partly subcrestal. So when you have it, this is the CBCD scan report, which mentions the same thing, 3.65 millimeter lesion size. Patient's pathological investigations were all normal. So here you can see bleeding time, clotting time, HbA1c, hepatitis, HIV, hepatitis C, and rest of the tests were all normal. So, and even the blood test, sugar test was also normal. So he was fit to undergo surgery. So just before the surgery, the root canal treatment was initiated and completed so that we really do not have to look into the root canal part during the surgery. So idea would be to reduce as much surgical time as possible. As you saw in the morning case, we had to obturate the canal during the surgery, so that takes away a little bit of a time during the surgery. Okay, so that was about the evening case, and we will be starting now. If you have any queries regarding the questions, you can continue messaging, and we'll be taking during the surgery all those questions, and even after the surgery. Thank you. Inject केलं? Good. Sorry. तिकडे इनफिल द्या. आपण जिंजिव्हेक्टमी करणार आहोत का? आस्क हॅज शी प्लान्ड? Okay, so before we start, the patient is being injected, and while we are waiting for the local anesthesia to work, I would like to describe the treatment plan. The plan would be to give incision, first a gingivectomy type incision to equalize the right central to left central, because we saw on the picture, if I can locate that picture back, let me go back to see if we can open that. Yes. Now here what I want you to see is the height of the central incisor that we are operating on is is less. The gingival tissue is much lower than compared to the left side central and even the lateral. So we can take an incision to remove excess gingival tissue so that we equalize the gingival zenith cosmetically, so we can take care of that as well. And we have talked to the patient, and patient has agreed for that, to take an incision to remove this much of gingival tissue in a scalloped way to get the cosmetic alignment at the gingival zenith as per this level. Then we give a subcrestal incision, and we raise the flap with a couple of vertical incisions on the distal of lateral and distal of lateral on both sides. Again, keeping cosmetics in mind so that we have equal recession or equal no recession. And then we raise a full thickness mucoperiosteal flap, and we will see the lesion right underneath. That lesion would be curated by placing trichloroacetic acid 90% into the lesion, allowing it to necrotize the tissue, and then curating it. So we keep applying it, and we keep removing the granulation tissue from the external cervical resorption till we are sure that we have completely removed all the granulation tissue and we can see clear dentine on the undersurface. Once we see that, we can irrigate the surface with sodium hypochlorite to disinfect it, and then on that surface we can apply, depending upon material we choose. There are choices of materials. We have MTA, bioceramic materials, and we have everything over here. But MTA does give some kind of a discoloration, so our choice would be to hide MTA and place glass ionomer on the surface. Also, the gingival tissue adapts well and heals well around the glass ionomer cement of all the materials, so we will retain the tissue in the same position with good healing. And coronally, whatever part is seen on the enamel part, coronal to the cemento-enamel junction, that we will be restoring with composite to match the color of the tooth and improve the aesthetics. So there could be a combination of MTA on the floor, glass ionomer towards the gingival or apical half of the lesion, and composite on the coronal half of the lesion. So it will be like a combined restoration of all the three materials, and probably that should help us better in retaining the aesthetics as well as the tissue healing. So I just thought we'll discuss, and after that we'll close the flap. There is no need to use anything else in this area, so we can simply suture it back to the normal level. Thank you.
Almost 2,500 is the registration.
No, 1,300. 3,900 total registrations.
3,900.
3,900. Jayaprakash sir is here.
He is coming here? Yes. Okay.
On. So we are proceeding towards the second surgical procedure being performed by Dr. P.D. Doshi sir. Okay. And we are thankful to Dean Madam for taking out time and being in the operating room for today. In spite of her very busy schedule today, she is speaking in the other event also. So we welcome you, ma'am, and please seek your guidance for a while.
Yes. Thank you, Abrar. Really, it's a proud moment for me that the Department of Conservative Dentistry and Microdentistry is conducting this second live workshop on microsurgery. The last workshop of 2024 was really a successful one with almost more than 2,500 participants in it. This time also, as soon as it was declared, we got a heavy registration. This around 3,000. This speaks about 3 to 4,000. This speaks about how much it is in demand. Everyone wants to learn this. This shows that there are learners who are really seeking for guidance. And we in GDC Mumbai get ample of cases, and the department is doing a wonderful work by doing microsurgeries. So this today's workshop, I think all are benefited with it. There should be a debate, there should be a discussion, because everyone has their own treatment options. And I hope the team is clearing this confusions which is in the minds of all the delegates. So congratulations to the team of microdentistry and conservative dentistry, and keep learning. Enjoy learning, I'll say, because learning is a continuous process. Thank you all delegates for participating in it. Thank you.
Thank you so very much, ma'am. This would not have been possible without your encouragement, support, permissions, and your enthusiasm. So we are very much thankful to you. And ma'am, there is a mechanism for registration, and there are WhatsApp groups which are made. We had a little bit of a hiccup regarding the WhatsApp because exceeding specific numbers, we were not anticipating more than 4,000 registrations to be received. So whichever WhatsApp groups were formed, a few WhatsApp groups were suspended by the WhatsApp app. So we had to again approach all the people through the same link from where they were registered. So that caused a little bit of chaos here and there, but taken care of. Right now we are running more than 2,500 people live, and more than 4,000 registrations, and people are sending us their doubts, their questions, and their academic objections, and their suggestions also through the comments on the YouTube and the WhatsApp groups which are active. So those are being received by 4 to 5 people who are sitting outside, and all the questions are processed. They are received by Dr. Manoj sir for the afternoon session, Dr. Kishore sir in the morning session. They are putting it up to the operating surgeon or the supporting surgeon. So right now the second procedure is being carried out in coordination between Dr. PD sir and Dr. Nilofer ma'am. Morning procedure were performed by me and Nilofer madam, as well as oral. So 3 departments worked on the same case, ma'am. I opened up the flap, curated. One extraction of the apical fragment of the root piece I could do. Second was displaced towards the intermaxillary suture, and difficult too. So we disclosed it using methylene blue. And then madam separated the tissues out. Samir sir was invited to remove it. So he extracted it. Then I did the obturation. Then we grafted the bone. And then we closed. Then madam closed it. So it's an interdisciplinary work, ma'am, being done. Thank you so much, ma'am.
Give your feedback, all of you.
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. Thank you so much for being here. Please inquire where has he reached.
he has gummy smile, passive tooth eruption suggest. We just now gave an external bevel incision to remove the irregular gingival margin. This patient has passive tooth eruption, that the tissue has not apically shifted during the eruption of the tooth. So this creates a gummy smile. So we correct that along with treating our patient for the flap. So right now we measure the coronal portion and approximated with the adjacent tooth. So this is we finished, and we got a regular gingival margin as confluence with the adjacent tooth.
So, as you can see, this particular job was combined with perio surgery simultaneously, and the external bevel incision reduced the gingival margin back to where it's supposed to be, in line with the left central incisor. So now we can go ahead and complete our incision, the regular incision, which will go from here to the lateral incisor distal border, so that, and it will curve towards the lateral incisor, so we will preserve the papilla over here. So I'll be giving the first incision over here in the interdental space and curve it towards the distal margin of the tooth, and then I can take internal bevel incision to separate the flap from the, and this incision will go to the crest of the bone so that the entire flap will be raised, and we are covering the lesion also in that. So this will go all the way up to the left central or lateral incisor, the choice is ours. And I'm going to go up to the lateral incisor, because see, the idea would be, since we are doing a cosmetic surgery simultaneously, we will be preserving the gingival outline. So now I'll be doing on the lateral the same way as I did on the other lateral. Vertical incision, I will go from the papilla, raise it, and then I will give a vertical incision, preserving the papilla and making sure that this angle is around 90 degrees. You can actually go around the incision one more time to separate the periodontal ligament fibers from the crest area, so that we can raise the flap properly. And now we can use the periosteal elevators to can you open it? So we can choose a periosteal elevator that will help us to raise the flap smoothly. As you can see, I can use something like this.
Sorry for the interruption. We have a small appreciation to make here. Dr. Jayaprakash Rathod, observer from Maharashtra State Dental Council for conduction of CD program is here. We welcome Dr. Jayaprakash Rathod sir, who is the professor and head of the department, BJ Medical Dental Department. Thank you so much for being here, sir. And I request Madam to felicitate him and handing over a certificate of appreciation.
So full thickness
I'm
flap.
happy to inform all of you that Maharashtra State Dental Council has allotted us 6 credit points for the program. So you all will be receiving certificates. Oh, wait 1 minute. One photograph. Sure, sir. Thank you so much.
So now you can see the lesion very clearly on the cervical area, and we are ready for curettage of the lesion. We'll need this excavator, and we will use TCA, trichloroacetic acid. A small one will be fine, these two. And we will remove the tissue. So it can be just curated like this, but you have to use some TCA to remove the base of the lesion. As you can see, it can extend into surrounding tissue from where the osteoclasts and odontoclasts come into the lesion. So this is TCA. Can we just dry it a little first? Okay, I'll hold it. So we place TCA on the surface, and you can see how easily it removes or cauterizes the granulation tissue. Don't allow it to go. You have to can we have a saline irrigation? So we irrigate now, remove the excess TCS, and then we curate it, and that's how we can complete the procedure. Sometimes maybe 2 or 3 such there are tags which are now seen because of the application of TCA, and we need to get them curated. You can even use a round burr over here to remove this granulation tissue as well as the dentine surface, which is underneath the dentine over here. And you can open this dentine. So I'm going to use my surgical erotor and a round burr to work on the surface. Very small round burr is needed because I don't need to do a lot of curating of the tissue. So here, as you can see, This is a surgical aerotor, and it can be used just like a normal aerotor, but it will not allow any. Can we have water, please? Can you, or you can just irrigate saline on top of it. You can do it with saline. So I can have water coming from the aerotor, or I can use saline as well. And you can see there are some tissue tags which are around in that area. We will check it one more time with TCA before we now that's the distal area where it was progressing into. So we have to find the margin and also open that. You can see I'm going under the lesion to remove all the margins, and looks almost all clean. But I'll just check it one more time with TCA. To see whether I'm not leaving behind anything. And it's just a little bit over here. Probably I need to go one more time, and that's it. And I've curated the lesion. So the last touch on the lesion. So just irrigate with saline that area, and we'll try and place rubber dam so that we can isolate the area for restoration. It is ready for restoration. Before that, I can also use sodium hypochlorite, but if I can place rubber dam first and then I use sodium hypochlorite would be better. Now in this case, I don't think I need MTA, because the lesion is not in the form of a class 3, it's almost in the form of a class 2. So, and the obturation is already done, so we don't find any cells below the lesion, on the floor of the lesion. So I can actually just get away by placing glass ionomer on the surface. And after the glass ionomer sets, we can place composite on the margin, which is going to be visible, which can be done even at a later date. There is no rush for it. The entire cavity can be filled right now only with glass ionomer. If someone can place the clamp.
मैं पकड़ती हूँ, मुझे दिख नहीं रहा है। से दूसरा है।
इसको ऐसा ऊपर कर लेने का हमेशा। Now, this is going to be a little bit difficult, but we'll try, because the lesion is Can we try it the other way around? No. Any other clamp we have? I'll try the clamp ulta. It's not fitting. Now this, दूसरा कोई क्लैंप कर दो। नहीं। So the lesion is isolated, and now we can, no need to put it. We can simply just leave it like this. There's no need to put the frame because it's going to be a direct vision. We can just irrigate it. And then we'll use sodium hypochlorite. After sodium hypochlorite, we'll use saline again, and then we will this sodium, no? Hypo, no? You have to irrigate very slowly so that you don't allow it to fall around. But you can see it's arresting bleeding and also cleaning the floor. Now I will I will use saline to clean it, and then I'll select the matrix that will hold the glass ionomer in place. So we can have the cervical matrices for the size selection. Yeah. Just wash it out. Be careful, huh? Clamp पकड़ के रखा है मैंने. I have something that fits exactly over there, as you can see, and now I will use that for holding the glass ionomer in place. And I'll actually hold this with an artery forceps so that it doesn't slip from my hand. Right? Okay, so someone can mix glass ionomer and give it to me. So you can see I'm holding it with an artery forceps so that I can adapt it without much of a problem. And this is ready for me. I prefer to use transparent matrices because you can even place composite if you want to at the same time. And you can cure through this matrix into the composite. So coronal area, if I want, I can etch and bond and apply composite. But we will actually fill up the entire cavity with glass ionomer, and then at a later date, we will just carve the glass ionomer and resurface it with composite. So it becomes a sandwich technique on the coronal part. Okay, so my glass ionomer is ready, and I'll pick it up and place it. And once I place it, I'm going to just place my matrix over it and hold it firm till the glass ionomer settles. And then I'm going to carve out the excess. So I'm just holding it patiently till it's setting. And I'll remove all the excess before I remove the rubber dam. Now we could have had a little bit of a thicker mix, but that's fine. You could also use RMGI, so or light cure glass ionomer, resin modified. So that also will allow you to set it fast, because the moment you apply light, it will harden. So that will save you some clinical time. But it's okay, we have time, and we just need another 1 minute for us to wait for the glass ionomer to harden. So you can check it outside, whatever excess is lying, to see whether it is hardened. Then I can remove my matrix. Please do let me know if it is hardened. Not yet. It's still not set. I think it's too liquidy. Do let me know what is the status. हो गया इधर नहीं हुआ है so I can still repair it. Or we can replace with a new one. Better. And give a thicker mix next time. Now next time what I'm going to do is place the glass ionomer and wait. When it is about to set, I'm going to place my matrix. So that saves me time and effort. You have to make it a little bit thicker so that you can mold it. नाही अजून पातळ आहे ते. Yeah. Okay, let me mix it a little more myself. हे बघा असा हातात मोल्ड झाला पाहिजे. त्याच्यानंतर तुम्ही टाकू शकता. Let's mix one more time. Just pick a powder like this so that it so we have mixed it again to make it set faster so that it adapts and doesn't get lifted from the I'll be placing the matrix now. And you can wait for about a minute after this. Now check whether it is set on the pad. Set. So see if it is set and then you remove matrix, you get a very nice surface and contour. You just need to now use some burr or 12 number blade to remove the excess. And then you're done. There's one more handle if you want over there in this. No, it's okay. She's putting it in the blade. No? I thought there is one more handle. Hmm. Yeah, I will use a thin tapered Fisher burr to smoothen. 12 number blade to remove the gingival access, and then a diamond burr to shape it a little further and remove all the coronal excess. And you can see now there is no need to worry about even the rubber dam over it. We can actually easily remove it, but I would like to remove it after finishing it, because in case you need to supplement it, you can always supplement it. This is my future composite area actually. You can see it's nicely merging glass ionomer. I can remove the rubber dam now and do last finishing and then close the case. Okay, so I'll do some final finishing before we yellow with a finishing burr, but I'll still use my surgical aerator because the site is open yet. Just verifying that I'm not having any overhangs so that I can close it. Fine, so that looks fine to me. I hope all of you also appreciate it, and we can just close now. We'll also close in the same fashion where we've done the gingivectomy, so we're going to have a good aesthetic outcome as well. And I'll be using 5-0 sutures over here because it's minimally exposed area. As always, start from the midline and go to the other side on the palatal aspect. Take a bite on the palatal area. Mirror, please. Keep the mirror here. The first incision, suture will go in the midline. It will hold the flap to its proper position. And make sure that you keep it firmly in place. Okay, so it can be cut now. Great. Anyone else want to try their hand at suturing? You will try? Okay, so our periodontist friend will try suturing.
Yeah, we have received a question about, can you brief about the whole case? So, sir, please brief about the whole case.
Okay. So since this was a class 2 lesion, it will be on one surface and not entering the pulp space. The case was very simple. We had to open the flap, but we also designed some amount of crown lengthening for the central so that it looks equivalent or equal to the other central appearance wise, because later on we will have to restore these two teeth with either composite or laminate or whatever we design for him. Then we gave a rectangular incision, and this rectangular incision is given on the lateral to lateral because we don't want unequal loss of gingival tissue. So we give it in a cosmetic region. We always give 2 into 2, 2 into 4, like that, So we have either central to central, lateral to lateral, or premolar to premolar, that kind of incision. And then we raise a full thickness flap, uncovering the lesion. And the lesion was very simple, as you saw. It required just some curettage with granulation tissue that was there in it. So we applied TCA, 90% trichloroacetic acid, and that would coagulate the tissue, and it will be easy for you to curate it out. You do it 2 or 3 times. You use also a burr so that every small area can be completely removed, and you also expose fresh dentine. Once you do that, you disinfect the dentine with sodium hypochlorite. And once you use sodium hypochlorite, again you use saline, so that now it is ready for, the surface is ready for bonding. So either you can use composite. We could have used a composite surface, but since part of the flap is going to go over the restoration, that part of the flap could get inflamed because of the material characteristics. So we decide to use glass ionomer on the apical half of the cavity and composite on the coronal half. Now, coronal half is not completed yet. It can be done at any stage in future. So once the healing takes place, the sutures are removed at that appointment. If everything is fine, then we can use composite restoration in a sandwich technique. So we don't even have to remove entire glass ionomer. We can just prepare a margin, excavate some amount of glass ionomer on the labial area, which is visible. And there only we place composite, merge it with the outline of the tooth. And then we can place, if we want, we can place a laminate, because patient also needs a lot of restorative work on those teeth.
And secondly, if you all must have noticed in the preoperative records, the right side gingival zenith had a problem. There was no bilateral symmetry, what we normally call it theoretically as passive eruption. So gingiva has to be replaced more towards the radicular portion. So the initial incision which was made was gingivoplasty. So first we trimmed off 1.5 to 1 mm of gingiva on the right side. And then we took a sulcular incision, then a releasing incision, then released the flap. So the surgery has served as gingival aesthetic surgical intervention. Again, endodontic intervention was done because there was pulpal involvement independently diagnosed. And then we went after raising the flap and plasty of the gingiva, we accessed the lesion, because we access the lesion of invasive cervical resorptions. Sometimes it goes this simple as it went in this case, or sometimes it can be like opening a can of worms. It goes on and on and on and on, and then you have to trace it microscopically along with it. And if it runs in the palatal aspect of the root, it becomes very difficult to trace it, access it, curate it with a burr or with any chemical. And the use of TCA, which was made in this case so easily, if the lesions are complicated, we decline the use of TCA. TCA is a caustic chemical. So sometimes it burns the oral tissues, or it can burn the normal adjacent tissues, which are very important as far as the healing is concerned. So in this case, sir could very controllably use TCA in the lesion. So it was good to use. Otherwise, do not attempt the use of TCA. Rather, in many of the countries, in many professional fraternities, TCA is being declined. I hope that answers the question.
Yes, that's why you saw the TCA was used with composite applicator tips. So we can precisely control the application only on the surface of the lesion and not all around.
with the suturing almost being completed here, it's time to thank everyone who has helped us, supported us to put this show together. At the outset, I want to thank our Commissioner, sir, Rajiv Nivatkar, sir, our Director, Chandanwale, sir, our Joint Director, Pakmode, sir, our Dean, Vasundhara Bhad, madam, all of them for granting us all necessary permission. Maharashtra State Dental Council, thanks to them for granting us CD points. And special thanks to Department of Oral and Maxillofacial Surgery for all their support and active participation. Dr. Abhilasha, Dr. Samir Khaire, sir, and special thanks to Department of Periodontology, especially Dr. Nilofer Attar for supporting and performing procedures live with us under the microscope. And big thanks to PD Joshi, sir. He has always stood behind us as a mentor, as a guide, and he has always been sacrificing his all personal practices and other commitments to teach all our students in this premises. Thanks to you, sir. And big thanks go to Digital Infomedia for making this possible to go live with the people. And thank you, Alchem Pharma, for helping us with registration of the people and connecting us to Digital Infomedia. And thanks to all the staff members, Dr. Kishore sir, Dr. Manoj sir, Dr. Sangeeta madam, Dr. Jyoti madam, and all the postgraduate students who have done the whole basic preparation of the patient, Dr. Aditi and the entire team. And very, very special thanks to Dr. Sandhya, under whose guidance everything was definitely possible. She's the one who has articulated and coordinated with everyone. And thanks to all of you for registering with us, trusting us, giving your precious and valuable time with us. And thank you for your valuable academic exchange. Your questions were encouraging, guiding, and they kicked off a thought process amongst us and you both. And whatever mistakes, nobody claims to be God, nobody is perfect. We have done whatever best possible to our capabilities, and we're looking forward to learning more and more from everyone. Thank you so much.
You can ask for feedback.
Yeah, feedback.
We would require some feedback from you so that we know, in future how can we improve our performance. At the same time, if you have any desire to see more procedures, you do send that in the feedback. So whatever maximum number of indications are there, that we will try and cover in our next episode. Thank you.
There is a team of people coming from Brazil. They have some relatives they want to visit. Now, ordering you had what very coming. So come here, sir. Come here, sir. त्यांना विचार किती मिनिटं लागणार आहे त्या लोकांना यायला आम्हाला बिझनेस विचार करायला रेकॉर्डिंग बंद करा म्हणजे परत चालू करते पॉज करा डोंट स्टॉप एनी प्रोसेस पॉज करून ठेवा सगळं ऑडिओ पॉज करा